And now it's my privilege to introduce our scientific chair, Professor Fazila Malik. Professor Fazila Malik is our scientific chair, and it's my honor and privilege. He is the international member of SKY committee. Second thing, he is the chief consultant of National Heart Foundation. And moreover, he is the pioneer in this case of complex PCI case, especially calcified lesion. He is the one of the best leader in case of managing calcified lesion.
I think we have to add another thing. Under his guidance, actually today's program and tomorrow's program, our conference, it is also done under his guidance, under her guidance. Thank you very much.
Persons, friends and colleagues, thank you for your very kind words. And it is indeed a great honor and privilege for me to be here today. So today I'll be talking about calcified coronary arteries. And we all understand that coronary artery calcification means problems. And it is indeed age and sex related. And when we are doing a coronary artery PCI, which is heavily calcified, we usually run the risk of having procedural failure and complications. And when we're trying to deliver a stent in a heavily calcified coronary artery, we might face difficulties. And during stent deployment, there might be underexpansion, asymmetric expansion, or malapposition. And indeed, we've heard quite a few talks, brilliant talks about the tools and the techniques that we have to tackle heavily calcified coronary arteries. But for me, the most versatile tool that serves all purposes is the rotablator. And I say that without any prejudice, because there are different clinical scenarios where rota is the only answer. And I would just like to illustrate a few cases, like this very elderly lady who had multiple comorbidities and was a very high surgical risk. Here, she had severe ostial left main disease and her vessels were heavily calcified. She had been refused surgery because of her comorbidities. And here you can easily appreciate that she would not be tolerating a very complex procedure and she would not tolerate bulky balloons there. So what we did is we wired the vessels and we first did rotablation from the left main to the LCX. We then proceeded to do rotablation from the left main to the LAD. After rotablation, we did pre-dilatation. We took our stent, we deployed it, and that was the final result. So frail elderly patients do well with rotablation. Another subset of patients who have a lot of calcium in their vessels are patients with chronic kidney disease. And such was the case for this end-stage kidney disease patient who was on dialysis. And you can appreciate the extent of calcium that the patient has. The RCA can be visualized angiographically, the extent of the calcium. So here we had to wire the vessel, took a rota wire, and then we did rotablation first with a 1.5 millimeter burr and then with a 1.75 millimeter burr. And we had to do rotablation to the entire length of the vessel. And this is something that rota can really tackle. Long lesions, diffusely calcified lesions, and lesions of narrow caliber. And these work well with rotablation. So after rotablation, we did pre-dilatation, first with a 2.75 millimeter NC balloon, then with a 3 millimeter NC balloon. So we did a very thorough job of pre-dilatation. And only after that, we took our drug-eluting stents, we deployed them sequentially, we did post-dilatation, and the final result was quite satisfactory. So this was the result that we got. And you would, I think, agree with me that we could not have got this result if we had not done the rotablation through the entire length of the vessel. Now, this third story is about a 60-year-old gentleman who underwent CABG 2 years back. And unfortunately, he started having chest pain again, and he had to be hospitalized. A check angiogram was done, and it was found that all his graft vessels had occluded. So we had to treat his native vessels and his ejection fraction was 45%. Now this is how his left side looks, and you can appreciate that the left main is severely calcified, and this is involving the proximal part of the LAD. The RC was also diseased, and this was a dominant vessel. So what we did is we first tackled the RCA, and this was the result after stenting the RCA. We then went on to tackle the left side, and we had quite a bit of challenge wiring from left main to LAD because of this huge chunk of calcium which was sitting in the proximal part of the LAD. However, with the help of a fine cross microcatheter, we were eventually able to wire the vessel. After wiring the vessel, we exchanged our workhorse wire for a rotor wire with the help of the fine cross. After that, we did rotablation with a 1.25 burr. After rotablation, we could take our IVUS catheter at this point of time. And with the IVUS, we saw that there was still a lot of calcium. The calcium was more than 270 degrees. So we went on to take a 1.5 burr. The aim was flag modification. We again took our IVUS catheter after our second rotor run, and we found that the osteo of the LCX was free of any significant disease. Now, this made us confident that maybe we would be able to get away with a single stent technique. And so we went for provisional stenting. We took a 4x34 drug-eluting stent after pre-dilatation. We positioned our stent, we deployed it, we did post-dilatation, proximal optimization, and we found that the LCX was doing fine, and also the IVUS confirmed that there was no significant plaque shifting. It looked just fine, and this was the final result. Now, this last case is again of a very frail, elderly 82-year-old female patient who had diabetic, had chronic kidney disease, and COPD. She had a very long history of chronic stable angina. Unfortunately, her angina was getting worse even after maximal anti-anginal therapy, and she was admitted in another hospital with unstable angina. They could not control her chest pain, and so an angiogram was arranged. They found that she had severe triple vessel disease along with the left main involvement. The vessels were heavily calcified. The surgeons in that hospital, considering her age, her comorbidities, were not at all keen to undertake surgery on the patient, so she was transferred to our hospital for revascularization. Her ejection fraction was 48%. And you will agree that frailty is a rather complex concept, but our patient was really way down the road in terms of frailty. And frailty is something that is multifactorial. You just can't cure frailty overnight, and it has multiple facets. So it was not like that we could cure a frailty overnight. So with the only option was to do a PCI for this very frail elderly lady. We knew that she would not tolerate a complex procedure at all. She would not tolerate a prolonged procedure. So what we did is we staged the procedure. We first tackled the RCA. She tolerated that well. And only after 4 or 5 days later, we went on to tackle the left side. And you can appreciate, even in fluoroscopy, the extent of calcium that she has on the left side. Now, this is how her vessel looked on the left side. And we knew from the very beginning that with this complex anatomy, she would require a double stent strategy, and she would not tolerate much balloon predilatation or bulky devices. So we decided upfront that we would be using rotablation for her. So first we did rotablation from the left main to the LCX. After this, we went on to do rotablation from left main to LAD. We first used a 1.25 burr, and after that, we still found that she had quite a bit of calcium sitting there in the vessel. So we stepped up our burr and we went for a 1.5 burr. After rotablation with the 1.5 burr, this is how the vessel looked. And as we have said that we had decided on a double stent technique, we went for the DK crush and we did that. And this was the final result after report with DK crush. And indeed, without rotablation, this would have been virtually impossible. So we would like to share our experience with rotablation that we have documented since January 2015. So from January 2015 to June 2021, we've completed our follow-up just last week. Again, we do a regular telephonic follow-up of our patients and they come and visit us every 6 months. So regarding the age distribution of our patients, 73% of our patients are above the age of 60. And indeed, more than a third of these patients are above the age of 70. So fairly elderly group of patients. Almost a third of our patients, that is 27% of our patients are female. The rest are male patients. And regarding the risk factors, now these patients are really sick and these are real super chip patients, if there's a term like that. So because 64% are diabetic, 91% were hypertensive, 63.9% had some form of chronic kidney disease. So real sick patients with multiple comorbidities. And regarding the type of lesion, 86% had long diffuse calcified lesions. The mean length of the lesions is 46 millimeters. So long diffuse calcified lesions in narrow caliber vessels. And among our patients, 215 of these 288 patients were real complex. 104 were left main disease, 42 patients were CTOs, 38 patients were post-PCI, 24 were post-CABG, and 7 patients had undergone CABG, then PCI, and again come with restenosis. So real complex set of patients, multiple comorbidities, elderly patients, very long diffuse lesions. We've managed to follow up our patients till date, and our mean follow-up is 32 months. That is almost 3 years now. And we're happy to say that 83% of these very complex patients are doing well. We have a death rate of 44 patients of our patients have died, that is 15%, and our overall of MACE is 16. Now, regarding the death, I must explain to you that 17 of the deaths, that is 38% of the deaths, was cardiac related. Rest of the deaths is non-cardiac related. And in fact, we have been really hit by the COVID pandemic. 32% of our patients actually died from COVID. 14% died from brain stroke. So 61% of the deaths were non-cardiac. And 83% of our patients, as I said, are doing well. And we have published our experience in a couple of journals. And in conclusion, I would like to say that patients with calcified coronary artery disease often tend to be elderly. They have multiple comorbidities. And due to these comorbidities, their frailty, these patients are poor candidates for bypass surgery. Their vessels tend to be diffusely diseased, heavily calcified, and often of narrow caliber. And indeed, rotablation is an effective technique to tackle such complex calcified cases. After rotablation, proper lesion preparation is of course mandatory, and after that, implanting a new generation drug-eluting stent can definitely optimize the outcome. But the most important ingredient, and as I always say, for tackling complex cases is the teamwork. And from the entire team of National Heart Foundation Hospital and Research Institute, Dhaka, Bangladesh, I would like to say thank you for giving me this opportunity to present our experience with calcified lesions. Thank you.
Thank you, Professor Fazila Malik, for your brilliant presentation. Practically, you have the highest number of rota also in Bangladesh. And regarding mortality, I like to know whether this mortality is in-hospital mortality or in follow-up mortality.
Okay. In our death, as I've showed, 17%
cardiac
death, right? Of this, 7 were in hospital. Now, these patients were very, very, 7 were in hospital, the rest 10 were out of hospital. As I said, we do regular telephonic follow-up.
Yes.
And so these patients, a third of our patients are above the age of 70. So elderly patients, multiple comorbidities, but these were cardiac deaths we could infer. But rest is most likely, others are non-cardiac.
The multiple comorbidities most likely is the most important factor for this death. If we analyze this death, and then we can say that multiple comorbidities.
Yes, we feel that due to the multiple comorbidities, these patients were very sick and
Fragile.
well as it is. And so that is one of the factors, definitely.
And may I request Dr. Ashok Sheth? May I request Dr. Sheth? You please comment on
I think
from Bangladesh.
Professor Malik's presentation was tremendous. It just takes my mind back to 3 or 4 important points. You know, I've been doing rotational atherectomies for the last 29 years. And even, and one of the first to introduce it in Asia Pacific region. In fact, we taught rotational atherectomies to Australia, Malaysia, and many of the countries in this region in the 90s. If I was going to give you a throwback, in 1994, of my 450 PCIs, 150 were rotational atherectomy, and the other 200 were directional atherectomy, and it was only 100 balloon angioplasty. So even in 94, we were doing 150 to 200 rotational atherectomies a year. I was doing rotational atherectomies a year. So you know, you think of those numbers and think of those years. But I tell you one thing, if you think rotational atherectomy, do it. You cannot proceed in life without learning rotational atherectomy. And finally, there are numerous balloon uncrossable lesions where only rotational atherectomy bails you out. In the present scenario, we have a variety of tools available for us for severely calcified lesions. Rotational atherectomy is one of them. Ultra high pressure balloons, IVL are the other 2. And then of course there are specialty balloons. But what I must make you understand is that when you come to real chip cases, even rotational atherectomy may not be sufficient. I can show you a whole spectrum of cases where 10 minutes of rotational atherectomy has not crossed lesions. And you have to go to another algorithm saying, what if rotational atherectomy doesn't cross the lesion? Those are the real chip cases. I agree with Dr. Fazila Malik that chip cases will always have calcified lesions in the present times. The incidence of heavily calcified lesions have grown tremendously in our practices across the world because of various patients with comorbid conditions. And we need to understand algorithms of not just rotational atherectomy, but what is beyond rotational atherectomy if rotational atherectomy does not work.
And I think you raise a wonderful question. How and what are the parameters to escalate the bar size in calcified lesion in absence of IVAS study? Dr. Malik, would you like to comment on this point? How and what are the parameters? How and what are the parameters to escalate the bar size in calcified lesion in absence of IVAS study?
Without IVAS or with IVAS?
Without IVAS.
Without IVAS.
Right.
Well, without IVAS, maybe if like you did, like most of the time we do plug modification, right? So you use a bar and then you take your balloon and maybe you are unable to still cross your balloon. Maybe then you would know that this is not good. So you would go and escalate and go for a higher bar size. Maybe that is one of the scenarios maybe where you would, without an
technical person, can you bring Dr. Ashok Sheth in the screen?
Professor Fazila Malik, we have another question to you. We have tried with balloon and there is dog boning effect with severe dissection of the vessel. What will you do in that scenario?
Well, actually, I mean, dissection is a relative contraindication for rotablation.
Rotablation.
Would hesitate to use this. So maybe you would go for other tools, but actually day before yesterday's, something like this happened to me. And the patient was surprisingly quite young, 40 years, and he had this just chunk of calcium in the middle of the LAD. And we did balloons and all, and we couldn't pass anything. So we knew that we had to do rota. There was a bit of dissection, so we went ahead and did the rota, and we didn't have any problems or any slow flow, but I suppose we were lucky. But I think I would request Dr. Ashok Seth to tell me what he would have done if he had dissection.
So,
Our dissection wasn't that bad,
So-
so we
so we
went
must-
away and got away with it.
I must address this because a lot of people are worried about dissections. You've said absolutely correctly. In the absence of IVUS, you just after rotational atherectomy with a 1.5 burr and usually a 2.75 to 3 millimeter vessel, you would go with a balloon, non-compliant balloon. And if you have dog boarding to somewhere like 17, 18 atmospheres, then it's time to just get back with a 1.75 burr. And by the way, dissections itself is
Technical
absolutely not a contraindication to doing rotational atherectomy. The only precaution you're going to take is not to swing the burr up and down that dissected vessel. Just bring it to the point of the lesion, which is undilatable. Just bring it close to that and just burr that area rather than do polishing runs up and down. So dissections don't bother us anymore at all. And we just need to do rotational atherectomy to those areas which are undilatable.
Actually,
Okay,
we did that.
Dr.
We just did rotate and it went fine.
So never worry about
Can you
dissection.
unmute yourself? Dr. Della Torre, can you unmute yourself?
Yes, I
Okay.
am.
Okay, I must appreciate when all of our speakers relentless effort to make the program success. And I really appreciate our Dr. Fazila Malik to present his great cases. Regarding your second case, that is end-stage renal failure patient, right? This is a really cheap, complex high-risk indicated PCI with CKD stage 5. But in our real practice, I think I should draw attention from Della Torre and Dr. Shed. In case of stage 5, is not a problem to tackle our complex lesion, but problem is that if it is stage 3 or stage 4, how can you tackle this situation? Complex high-risk indicated PCI with CKD stage 5, not a matter to tackle as because it is a dialysis mode. So he or she lead as a normal life because kidney function is work as before. But problem is that when patient is stage 3 or stage 4, till today we have up to not enough strong evidence to tackle. We are usually tackle up to stage 2, but sometimes we have to tackle stage 3 and stage 4. Stage 3 we can tackle with enough good evidence, but stage 4 we don't have enough good evidence to tackle the situation. Do you have any explanation or any experience how to tackle this situation?
Are you asking to me? Sorry.
Sorry?
Is my question to me or is a question
Yeah, both of you are volunteer. You can answer.
Okay, it's a very tough question because you know that advanced chronic kidney disease is the most complex setting you can face, you can challenge in PCI because these patients are in a very high risk for every stratum of bleeding or ischemia. They have a lot of calcification. They have the highest risk of restenosis. They have the highest risk of thrombosis, but also bleeding. Then I think it's a very unfortunate situation when you have really to be very, very careful of the balance of risks. But the problem is that in these cases, all of the risks, both risks are very high. So I like the presentation that was presented before because in these patients with advanced kidney disease with a huge calcification, the best preparation of plaque, the larger the room you leave for the stent that you're going to implant afterwards, the good DS selection, and finally, the best APT therapy that should be very dynamic. You can maybe plan for 3 months, but if the patient is bleeding at 1 month, maybe you have to stop, or maybe after 3 months is not bleeding, you can stent the indication. Very important, the APT is a dynamic indication that you can change along the evolution of the patient. It's not something you have to fix in advance. And also I want to highlight the number of lead main PCI in the study, in the cohort of rotablation. This is new. This is not common. 20 years ago, 15 years ago, we were not doing so much rotablation in the lead main, and now is the main indication in the Malik series, which is really outstanding and really important to think about, because lead main now is here to stay as a very common indication for PCI in very complex patients.
Dr. Shet, can you add something?
I think importantly, one has to protect the kidneys, which basically means that you need to stage the procedure and you've got to practically get more and more familiar with imaging and zero contrast PCIs, and certainly deal with only the vessel which matters. So I don't think we're aiming for a complete revascularization in many of these patients. We want to preserve their kidney function, and therefore imaging with intravascular ultrasound leading to minimal or zero contrast PCI becomes something to be familiar and learn more about.
In the line of Dr. Sheikh, it's very important to establish a very good indication for PCI. Then pressure-wide assessment is important in these patients to do just the procedure that is needed. Second, IVUS is essential. Forget about a lot of contrast, forget about OCT. IVUS is the way to go to make the proper selection of the preparation of the plaque to stenting optimization. You can do the procedure with minimal contrast and to optimize the result as much as possible to prevent restenocyte thrombosis. And these are very good advice. And that's along with saline hydratation, and you cannot do much more. But I think with these 3-4 different guidelines, you can do a lot of good job for this patient.
Dr. N.M. Mominuzzaman, আপনি কি আমাদের সাথে আছেন স্যার? Dr. N.M. Mominuzzaman, Dr. A.P.M. Sohrabuzzaman. Then we can wrap up the program as because both the concluder are absent. Azam?
Yes, okay. So really it's our honor and privilege to organize such a wonderful program with the leadership of our President, A.K.M. Fazil Rahman sir, and our dynamic Secretary General, Professor Mir Jamaluddin. And I must give all of my executive committee members who gives strong support to us to organize such a program and continue the program all day long and 2-day program. And we believe we enjoy the program